Welcome to the Mayo Clinic Orthopedic Surgery Podcast, a curated series of interviews and discussions highlighting the three shields of orthopedic surgery at Mayo Clinic: clinical practice, research, and education. Welcome back to the Mayo Clinic Orthopedic Surgery Podcast. We've got another great clinical highlight today talking about hip and knee arthroplasty. Particularly, we're going to talk about hip arthroplasty and the role of extended trochanteric osteotomy. It's an old technique, but one that we continue to sort of reinvent and evolve over time. I've got Dr. Matt Abdel, who's professor of orthopedic surgery here and one of our hip and knee reconstruction surgery surgeons, and does a very high volume of revision and complex total hip arthroplasty. Thanks for joining us today, Matt.
Thanks for having us, John. It's an exciting area of exposures and how to manage the femur during revision hip arthroplasty.
That's great, and obviously these areas are things that people do, but I think there's not a lot of sophistication sometimes in terms of how we do it. And so I know you've been writing a lot about this. So can you tell us a little bit about common modes of failure of hip arthroplasty in the modern era?
Yeah, so I mean, hips can fail via a variety of formats, and it's based upon the time in which they were done. So traditionally, they were polyethylene wear and osteolysis. That's with conventional polyethylene. And more contemporarily now, it's based upon periprosthetic joint infection and hip instability. Hip dislocation is the number one cause of why revision hip arthroplasties fail, and the number one aseptic reason in which they fail. And there are still component issues. Even though surgical technique and implant designs improved, hip revisions are still increasing because the actual volume of hip arthroplasties being done primaries is also increasing. So the absolute number of revisions is greater than ever right now.
As busy as you guys are in terms of the hip and the hip revision practice, it sure seems like that from the outside. So there's always going to be a need for these techniques to manage these more complex situations. Can you describe some of the reasons why you choose to do an osteotomy, and maybe even more specifically, why indications in which you'd say you wouldn't need to have an osteotomy?
Yeah. So, extended trochanteric osteotomy, in my hands and my thought processes, is the single most powerful revision technique you can have. It allows me to access the femur for well-fixed components, including distally well-fixed uncemented components. It allows me to access the femur and cement mantles distally. It allows me to correct sagittal or coronal deformities in the proximal femur. It allows me to gain acetabular exposure, so pelvic discontinuities, custom hemipelvis reconstructions after tumor reconstruction, so you get better acetabular exposure. And maybe most importantly, John, in 2020, it allows me to put in the most common stem safely and reliably, and that is a modular fluted taper stem, in which I want the fluted taper portion of stem to gauge the distal femur for axial and rotational stability. Now, when would I not do it? I would not do it in a routine hip femoral component that I need to remove from the top, that I can remove from the top that's got metaphyseal fixation if it's uncemented, or a cemented stem that's got a short cement mantle. So metaphyseal fixation, uncemented stem without a trochanter that's in the way, I can get that from the top. Short cemented stem without a long cement plug, again, trochanter on the way, I can get that from the top as well.
Is infection a contraindication to osteotomy in which you're going to have to fix the osteotomy, or is that a technique that you sometimes use?
No, it's probably the most common time in which I utilize it. It's when I've got a trochanter that's at risk. I need a thorough debridement. I've got to get every bit of that cement and foreign debris from the canal, or I've got a revision component which I need to remove and get all of that hardware out. I'll utilize that. What I will change, John, is how I fix that osteotomy at the end. So traditionally, if I was doing an aseptic revision, I'll utilize two cables, one a centimeter distal from the distal aspect of the osteotomy and one right below the lesser trochanter. In these scenarios, I'd utilize two wires, monofilament wires, just like as we close infection cases. I don't want polyfilament suture. I want monofilament wires, monofilament sutures.
That sure makes sense. One of the things that, as a simple shoulder surgeon, always remained a little bit confusing to me was the different styles and eponyms in terms of the osteotomies. Can you describe the orientation of those osteotomies for the surgeons in practice?
Yeah, I'm going to summarize it. We just recently published our paper in JBJS American, and this is an area of confusion. So we've summarized the two big flavors of osteotomies. There are laterally based Poprosky, Dr. Wayne Poprosky from Rush osteotomies, in which the lateral third of the femur, including the greater trochanter, is elevated, most commonly utilized by posterior approach surgeons. The second osteotomy is a so-called Wagner or anteriorly based osteotomy. Classically, those are utilized by surgeons that utilize anterolateral or modified anterolateral approaches, in which the anterior third of the proximal femur is elevated, including the anterior third of the greater trochanter, and it gives you access. I use both. If I've got a coronal deformity, I may use one. If I've got a big sagittal deformity, particularly a big bow anterior in the femur, I'll utilize the other, the anterior-based Wagner osteotomy. The final thing I'll just say is those are the majority of osteotomies at the Mayo Clinic. There are so-called transfemoral osteotomies, and people confuse that. And what a transfemoral is really the Wagner osteotomy, but it goes down to, I use in periparasitic fractures, it goes down to a certain length, usually 12 to 16 centimeters, and both the anterior and posterior limbs are osteotomized. So you actually have three different pieces: the distal femur, the anterior and posterior aspects of the osteotomy there. So that's how the transfemoral, people confuse that, is different than the Wagner or the Poprosky osteotomy.
And would you consider both the Wagner and the Poprosky osteotomies in the ETO classification, or is it ETO only used for the posteriorly based osteotomies?
All of them are going to be ETOs, and I always kind of think about it that once I've gone past the trochanter and past the ridge and where it kind of goes from the taphosis to metadiaphyseal flare, that is an extended trochanteric osteotomy. So traditionally 12 to 16 centimeters, whether it's laterally based, anteriorly based, or transfemoral, all of those are ETOs.
Perfect. Super helpful to give some clarity there. Can you talk to us about your mechanisms for, let's say you're going to do, choose whichever one you do more commonly, but talk to us about your steps, how you measure, how you determine where you're going to make it, and how you complete it, and some areas where you could get into trouble in terms of the terminology I've heard before is the grenade osteotomy, where you're trying to put things back together because it all kind of went sideways on you during surgery.
Yeah, I mean, you clearly want to avoid the grenade osteotomy, and it's all with planning. I always say there's 7 steps to doing a good ETO. So the first step is you're going to want to plan it. So I'll plan the fluted tapered portion of the stem, which is usually what you're going to put in for an ETO, and I'll plan on X-ray where the other stem has failed or ends. Make sure I have about 2 centimeters isthmus in contemporary practice, and how I can build that up. That's how I do my length. It's either 12 to 16 centimeters. Number 2, expose appropriately and do a subvastus approach. I'll do a subvastus, usually a couple of centimeters distal to my osteotomy length. Let's call it a short osteotomy, 12 centimeters. I'll do subvastus exposure, 2 centimeters distal to that, so I've got access so I don't shorten the fragment. Number 3, do the posterior limb of the osteotomy. Usually I'm going to do a Poprosky. Most of the time it's a lateral third. Number 4, take a small saw and do at 45 degrees the transverse limb of the osteotomy, but do not connect the posterior limb and transverse limb. That would be a stress riser. I'll come back to that. Now, next, you're going to do the anterior limb of the osteotomy because you got a subvastus approach. So don't wait for the osteotomy to crack in the wrong spot. Go as anterior and proximal as you can. Number 6, you're going to want to connect the anterior and transverse limbs and the posterior transverse limbs with a pencil tip burr, because then it's kind of rounded nicely. And then finally, you're going to want to have patience with wide osteotomes going over the lateral shoulder of the implant, elevating the lateral third of the femur. So I'll usually put 2 20-millimeter osteotomes and gently tap them individually going forward and minimize that urge to lever on it. Allow it to go over. That osteotomy will osteotomize. That's why it's called osteotomy. Osteotomize itself and then open up the femur on its own.
That's really helpful. Thankfully, all of us orthopedic surgeons are very patient, so we can just patiently, especially in the hip and knee arthroplasty world, right, Abdel?
Yeah, right.
So you just wrote up a massive series of these patients who had ETOs at Mayo Clinic. Can you tell us a little bit about what you found?
Yeah, so we looked at 612 ETOs. They were done between 2003 and 2013, mean follow-up of 5 years. That's why we ended in 2013. And it was remarkable. Kind of the big take-homes from that are 98% of osteotomy fragments united, John. 98%. Number 2 big take-home. It took about 6 months for the unions to heal, the fragments to unite. So be patient with them. We see them at 3 months, and I usually see them at 4 to 5 months, but the mean was 6 months. Number 3, there was some osteotomy migration, but it was minimal. It was only 3 millimeters. And finally, the number 1 complication was indeed osteotomy fragment fracture. Intraoperatively, that occurred 4% of the time, and postoperatively 0.5. So what that told me, because it was 8 times more common intraoperatively, is be patient at that one step we just talked about. Be patient. If you don't fracture it intraoperatively, the likelihood of that having any issues postoperatively is very, very rare.
That's really helpful. And I'm going to sort of summarize what we talked about, and then you can add any further thoughts that you have about it afterwards. But it sure sounds like the extended trochanteric osteotomy family is a tool that we should not forget about, and we should potentially even use more liberally than we do now. And I think as a non-hip and knee arthroplasty surgeon, I would have a high threshold to do an osteotomy, but it sure sounds like with a fairly standardized technique, you can do this in a relatively efficient way with a relatively low rate of complications, both migration and otherwise. And I think anybody, I do osteotomies in the proximal humerus, and I always am surprised at how much better exposure I can get, particularly of the canal and debridement with infection. So probably a technique that we should consider using earlier rather than waiting for it to happen on its own. And the Mayo series certainly supports that with just almost perfect clinical outcomes or healing rates after surgery.
Yeah, that's right. It's an extremely powerful technique that protects the trochanter, tissue sparing approach, and it really has facilitated the most complex of revisions and converted them into relatively straightforward revisions. So keep it in your bag of tricks and keep it at the top of the list in your bag of tricks.
Thanks for your research on this. And if some of our readers want to see, obviously this is a pretty visual thing in terms of thinking about how to do it, where should they look to learn more about the techniques for doing this in their practice and streamlining it?
Yeah, good question, John. So the paper we published in JBJS American, in there's several illustrations, intraoperative pictures. Several of the patients are mine. And we've also got a JBJS Surgical Insights that will go into that particular approach step by step. And I've also narrated a video of me doing one that will give the reader and the surgeon some additional incremental information, specifically on surgical tips and tricks.
Beautiful. I think I could probably do one after hearing you talk about it, but how about I just keep sending them to you for a little while? Does that work?
You're kind. Send them all over.
Perfect. Thanks so much for joining us, Dr. Abdel.
Thanks, Dr. Marlowe. Pleasure.